Hello guys, welcome back once again to Pathology by Ranjith, our YouTube channel. So here I'm going to start a series of discussions which are primarily targeted for the FMG students. I'm going to start from way back from FMG 2020. This is a paper recall from December 2020 examination of foreign medical graduates. And slowly we'll be moving to 21, 22 till 24, 25, right? So if you are attending this year FMG exam, I hope this recalls might come in handy. We'll go little bit into the depths of the questions, the way to solve the questions, maybe tricks or mnemonics, something to remember, right? If you're first time here, click on the subscribe button. Let's learn more pathology and medicine together, right? So let's start. So it's a very simple and a straightforward question. I don't think you would require options for this question. It's a classical 5-year-old boy presenting with weight loss, fever, painless swelling in the jaw, right? That's classical, fine. So two important findings here. See, it's a scenario-based question, a very simple scenario. This is, I'm sure everyone knows this is a classical starry sky, right? The starry sky appearance, I'm sure you must have made the diagnosis undoubtedly Burkitt's lymphoma, right? So that's not our concern here. Our concern is how to approach a question. Whenever it comes to lymphoma and leukemia, one of the easiest thing which you can look at is the age. If you keep this in mind always, a child having a leukemia, it's most likely ALL. A child having a lymphoma, most likely it's Burkitt's. These are the only two things with respect to hematolymphoid malignancy which can happen in children. Rest of them will happen in adolescence or adult. Most of them will happen in adult age group, right? So leukemia in a child is ALL, lymphoma in a child is Burkitt's. That's more than enough for us to diagnose. And this is also an important PYQ. The most common site of Burkitt's lymphoma is in the jaw. You Google Burkitt's lymphoma, look at the first image. There'll be an African kid with the jaw swelling. Classical of Burkitt's lymphoma. And it's a beautiful starry sky, right? So answer is pretty simple and straightforward. I'm sure you guys must have said it's a classical case of Burkitt's lymphoma. Kikuchi is kind of an autoimmune hypersensitivity inflammatory condition which happens in lymph node. Kikuchi is not something which commonly comes for an FMG, gets not even for an MBBS as of now. You just remember, if you can remember this. Whenever you see Kikuchi lymphadenitis with cytopenias, always suspect lupus. That's something I want you to remember, right? Infectious mononucleosis is a EBV related inflammation, as simple as that. With respect to entrance exam, you have to remember that infectious mononucleosis in a blood smear, right? You have a classical finding in blood smear which is called as a Downy cell, right? That might be very, very characteristic finding. There's a lymphocyte which kind of destroys the infected cells, right? So these Downy cells are nothing but an activated lymphocytes. Normal lymphocyte cytoplasm will be very minimal, right? So this cytoplasm will be a little bit more. It'll be a little bit abundant cytoplasm. Because of the abundance in cytoplasm and the indentation caused by the RBC, the cytoplasmic membrane becomes like this. Because of this, it has a famous name called as an ballerina skirt appearance, right? It looks like a skirt, the ball dance, like the ballerina skirt appearance. The normal skirt, what you see, it looks like that. So we call it a ballerina skirt appearance. A Downy cell, a classical MCQ which can come for sure. Hodgkin's, everyone knows about Hodgkin's, right? I not talk to you about Hodgkin's lymphoma by default, right? So let's go to the next question. A very simple one. I hope that these questions become very simple and easy like this, right? Graft from an identical twin is called as an, it's nothing but an isograft. Allograft is something which is an same human species but genetically non-identical. That's all. If they are genetically non-identical, we're going to call it an allograft, right? Autograft is from the same individual. See, if I'm going to peel a part of a skin from me and give it to me, it's an autograft, right? Split skin graft is a very important example for an autograft. Not just that, even we do autologous blood transfusion. For an elective surgery, we take the blood from me a couple of weeks back, store it in the blood bank. After surgery, we can give. Even autologous bone marrow transplant also been done, right? Xenograft is something from another species, which are rare these days. One of the classical examples of xenograft we have discussed multiple times is a porcine heart valve. We transfer pig's heart valve to human beings. We were doing it. Nowadays, we go with metallic valves, which is much more durable. The biggest problem with xenograft is it's a biological material, right? Over the time, it will definitely degrade by itself, right? So the answer is simple. It's an isograft which happens between genetically identical twin. Please do remember a non-identical twin, right? A non-identical twin or a dizygotic twin will come under allograft, not under isograft. Very, very important. Fine. Okay. Next question. Simple, very simple question, scenario-based question. A 9-month-old kid, progressive pallor, abdomen distension. On examination shows hepatosplenomegaly, malar eminence is there, and peripheral smear is shown this. I'm sure you guys may have jumped and said, we see target cells. If it's a target cell, it has to be a thalassemia, right? And also hemoglobin is low, menstrual index is less than 13, which what is the most common diagnosis here? Actually, there are multiple clues in this question. Right from the age, 9-month-old progressive pallor, very unlikely for a megaloblastic anemia or a pernicious. Pernicious is also by default megaloblastic, right? IDA can happen at 9-month-old, but there should be a reason, and progressive pallor is very unlikely. Hepatosplenomegaly, malar eminence, these all points to just one more MCQ. I want you to remember this guy: chipmunk phases or hemolytic phases. Because the bone marrow becoming hyperplastic, this part, all these bony prominences becomes more evident there, right? And there's one more classical finding here: the target cells in the peripheral smear and Menster's index. I want you guys to remember about two important findings: RDW and Menster's index. These are two things which help us to differentiate IDA versus thalassemia, right? A very simple way to remember, right? Thal-less. You must have read this a lot time, right? Everywhere in the pathology department across the world, they use this. Thalassemia. If the RDW is normal or narrow, it's smaller, right? Mostly normal or smaller. Menstrual index less than 13. 13 is the fancy number. Thalassemia. Wider RDW seen in case of an iron deficiency anemia, and Menster's index will be more than 13 in case of an iron deficiency anemia. In our detailed lecture at PW Med, we have seen what is the reason for this also. If you want to have a look at that, go and have a look at that as well. Fine. Reasoning is not what I'm going to discuss here. It's the approach to the questions which we'll be discussing in this entire series. The answer is a classical case of a thalassemia. Major or minor? What do you guys think? I want you guys to comment in this section, in the comment section. Is a thal major or a thal minor? I'll leave it to your audience. Fine. The next one. Superb question. I'd appreciate this sort of standard questions coming in exam. 60-year-old, anemia, hepatosplenomegaly, peripheral smear shows teardrop cells, nucleated RBCs, giant abnormal platelets, and bone marrow biopsy is seen here. What's the most likely diagnosis? See, teardrop cells or dacrocytes, the other name of teardrop cells, this also can come in exam. Dacrocytes is a classical finding of myelofibrosis. Please remember that normal bone marrow, the RBC squeeze and come out, right? Imagine it's a fibrotic bone marrow. Not an enough space, it cannot come outside. So it kind of squeezes more and comes like a teardrop, right? So RBC is having a teardrop appearance, which because coming from a squeezed bone marrow, a fibrotic bone marrow, right? Look at the biopsy here. This bone marrow biopsy, there are a few things you want to remember. This is actually a reticulin stain. A reticulin stain is done for bone marrow fibrosis. Generally, it will be grade 3, grade 4 fibrosis. You can see all the black lines, right? Those are the reticular fibers increase in the bone marrow. Also remember, megakaryocytes. I'm not talking about the peripheral smear. I'm talking about the bone marrow. Megakaryocytes will be very abnormal and atypical and increased in number. In case of myelofibrosis, do remember this as well. That's kind of the initial starting point. More megakaryocytes, more PDGF, more fibrosis. That's kind of the pathogenesis which I want you to remember by default. Why does nucleated RBC come outside? That's also a very important finding. Remember this, since there is no space in the bone marrow, all the precursors come outside. Very important term. Never forget this term. You have to look for this term in case of myelofibrosis, leukoerythroblastic blood picture. Fine. It's a very important finding. Why it's important? Because it's a clue. Leukoblast, that's precursor of leukocytes. Erythroblast is not having enough space in the bone marrow coming outside. One of the finding is primary myelofibrosis. I don't see this in polycythemia vera. Last place of polycythemia vera can go into myelofibrosis. That also is here, right? Essential thrombocythemia is not going to present anemia. It's thrombocytes, right? More and more of platelet counts will be there, right? CML definitely not. CML will know a classical finding of CML by default, right? Also do remember, this also can have a massive hepatosplenomegaly because the bone marrow fails. There will be an extramedullary hematopoiesis happening in the spleen and the liver. Okay, fine. That's the right answer here. It's a classical case of primary myelofibrosis. Fine. Let's go to the next guy. Simple thing. I'm not going to spend much time here. You guys know the answer, right? Straightforward and easy answer. Teenagers swelling in the face, tongue, the difficulty in breathing. Type of hypersensitivity is type 1. Immediate hypersensitivity, IgE mediated hypersensitivity. It's immediate, and one of the cells involved, the two cells I want to remember, mast cells and eosinophils, are the guy which is going to be involved in the progression of this hypersensitive response. Type 1 always has a sensitization phase. If there is no sensitization, we call it anaphylaxis. It's a very immediate, life-threatening, without sensation pain. We call it an anaphylaxis, right? Please do remember that. Okay, that's all few things to remember about it. Tau protein inclusion. See, there are in most of the exams, there will be few questions like this, which are like bouncers. I don't see these questions normally. These are pure bouncers, right? Top protein inclusions are involved in which of the following disease? The answer is clear-cut: Alzheimer's disease. So what is top protein? We have to read about that, right? You might not get this back again, but if a bouncer comes in EPG or FMG exam or an INC exam, this table or this image from Robbins can help us a lot, right? This is the normal amyloid precursor protein. If you remember the case of amyloidosis, what we discussed, amyloid precursor protein is where the A beta amyloid comes from, right? In Alzheimer's disease. Now, a normal amyloid precursor protein can have three cleavage states: alpha, beta, and gamma. Secretase activity, right? Normally, look at this, it's a non-amyloidogenic. In a normal person, you and me, what generally happens is you'll have alpha and beta activity. Alpha and gamma activity. If there's an alpha and gamma activity, okay, this dissolves. The COH side, this also gets reutilized, and this also will be metabolized. No problem at all. The moment APP becomes older, obviously my body will cut it and reuse it like a normal activity. But in people who are prone for amyloid or prone for Alzheimer's, what will happen? You will have beta gamma activity. There are few predisposing conditions. More of beta secretase is there in a person, obviously we'll go for this, right? And also, if there's excess amount of APP, can result in this. That happens in your Down syndrome because APP is in chromosome 21. That also is something which can come in an exam, right? So whenever you have more beta gamma and no alpha, this will dissolve. This will be gone. But this becomes an A beta peptide. This is also an MCQ, right? A beta amyloid is seen in case of an Alzheimer's disease, right? So this A beta slowly accumulates and becomes like an aggregate. This aggregate is a problem. This aggregate kind of has multiple, I want to destroy them, right? So it's a protein aggregate. So I do lots of things to try to destroy them. This aggregate also allows kinase activation. The moment kinase gets activation, tau phosphorylation happens. Tau phosphorylation is a chemical modification which happens in the protein, right? That tau aggregates forms the neurofibrillary tangles and the plaques. Amyloid, fibrillary tangles and the plaques that completely destroys and cultures the neural damage which results in your Alzheimer's disease. Sometimes down the road, we'll also go and look at the genetics of Alzheimer's. What are the predisposing factors in future, right? But for now, what is tau and how they are formed and what activity causes Alzheimer's be very important. Alpha gamma is normal, beta gamma is abnormal. Okay? That's something which I have to remember. And tau protein deposition slowly and steadily degrades the nerves. And once nerves is gone, there's no coming back at all, right? That's about a little bit about tau and Alzheimer's, right? Next question. Simple, straightforward. Old age, cardiac tissue, brown color pigment. Nothing but an lipofuscin pigment, right? The wear and tear pigment of cell injury. You can see them in old age. You can see them in inflammatory condition. It's a lipofuscin accumulated pigment. That's all, right? Nothing much to discuss. Very simple guy. Okay, let's go to this. 35-year-old bleeding epistaxis, gum bleeding, ecchymosis. Platelet is reduced, hemoglobin is reduced, TLC is high. I'm talking something in terms of a WBC neoplasm, but unfortunately, all for a WBC neoplasm, right? Okay. Now, there are two repeats, ignore that, fine. Blasts are CD33 positive. The moment I have the term blast, I'm going to think of an acute leukemia because acute leukemia is where you have blast more than 20% in the blood or bone marrow, right? I don't call blast in case of a chronic leukemia. Chronic leukemia is generally your mature cells, right? So this can be ignored. Myeloid or lymphoid can be ignored to some extent, right? Now, if you look at these blasts, the blasts have tiny bit of granules. I do have granules in the blast, and if you look carefully, look at this guy. What guy is this? That guy is OR rod. Not just that, actually, no, the 33 positive is also a clue. Though the best marker for myeloblast is MPO. MPO is the defining marker. 31, 33 is also positive in case of a myeloblast. Do remember that, right? Mostly is MPO positive. That should be more than enough for me to say, okay, it's a acute myeloid leukemia. Classical finding, fine? Okay, 83% blast has to be acute, cannot be chronic at all, right? Perfect. Okay. Let's go to this question. I think this is the last question of the FMGE 2020 December recall. And like I said, subscribe to the channel more. I'll keep uploading one by exam recall so that at the last, if you want to quickly recall, look through everything, this will be the go-to place. Fine. 3-month-old, 6 months of clumsiness, leukocoria, absent red eye reflex, diagnosis. It's already done, right? Retinoblastoma, right? Molecular analysis indicates loss of cell cycle control. What's the finding? And this finding is a rosette. You see cells like this. Fine. You have cells like this. and then you have a pink color cytoplasm coming from the cells, and then in the center you have an empty hole. There's a classical finding for Flexner Wintersteiner rosettes. Fine, classical finding. The moment you have a central empty space or a lumen, we call it a true rosette. Fine, it's a classical Flexner Wintersteiner rosettes seen in case of a retinoblastoma. Right, age, location, and also the microscopy is a diagnostic clue. Fine, that's all for today. See you soon in the next session. Till then, bye bye from Dr. Ranjith. Bye bye.